right, good to go, Angie. And I'll share.
Okay. Can you guys believe, Andy and I were talking about this earlier, we are on our last session already, but this isn't the last you're going to hear from me. And the reason being is this is really the learning collaborative part. This is where we really start to dig a little bit deeper and get to know where our resources are and looking at how we can build some additional resources for you all. So we'll go to the next slide. All right, learning outcomes. So I'm going to talk a little bit about the one-on-one calls. We're going to do a little bit deeper dive into tracking data and demonstrated success. And at the end, eventually, within hopefully a week, you guys will get some tools and resources along with establishing some communication techniques with hospitals. But first, this is really a very interactive group today. And is anyone else interested in taking notes alongside me that would be willing to send them to me when we're done, just in case I miss something when I'm trying to jot and talk at the same time? Come on. It won't be hard, I promise. And all you have to do is listen for some key things, you know, and you're like, ooh, I want to remember that because I'd like to see that in the resource packet or something like that.
Angie, this is Danette. I typically take those kind of notes. So I will take notes. Maybe, a couple more people could take notes and we can all share.
Yep. Anybody else? And I'll be taking notes as well.
I just wanted to say, I usually take notes. So if I have something to share, I'll definitely send it to you.
Perfect. Thank you. All right. So next slide. So a recap of the one-on-ones. Oh my gosh, I loved all of our individual chats that we were able to hold. You guys are doing amazing work. And from those that have been skilled and experienced to those that are more of the early learners, you get it. I heard from everybody, session 2 was definitely a key win for really identifying outcomes, where some of the data comes from, and looking at how we can build from that. In talking with everybody, it looks like there is a huge mix of consortium work and individual grants, with the primary utilization of the SHIP grant being on individual grants. Several contract that SHIP grant project out. And so when we get a little bit deeper into this today, we're going to talk a little bit about your subcontractors and certain data points that you can start asking for or you're currently asking for to help you build this, especially over time. And then the various levels of needs and skill sets. I tried to help as many people out as I could at the time. There are a couple of folks that I still need some additional items to send back to you, and I'm working on that. But overall, the greatest gap is hospital engagement. And I think you guys probably would all agree with that. It's getting them to send you something. So how can we make it better? So go to the next one. So we're going to start with some asks. So the first thing is, in our toolkit, I repeatedly heard, what are others doing and what can we do with these projects? So I'd like to talk to all of you, for those of you that definitely subcontract out some of your work. Would one of you share 1 or 2 or 3 your favorite subcontractor project, what they did? Now, this can be anything. It can be your charge master reviews. It can be, MVQIP. It can be your HCAHPS. But how you looked at that project, the data they returned, the vendor used, and how you decided on your subcontractor. Was it by RFP, prior experience, you were already working with them, somebody referred them to you? What is it you did to utilize that subcontractor? It could be just your hospital association.
Hey, Angie, this is Lori Gert with the Indiana Hospital Association. I do have do have a favorite subcontractor project that we like to brag about. It's our simulation project, and it's through the Rural Health Innovation Center located out of Terre Haute, Indiana, which is central west Indiana. The exciting news is they just got national certification and accreditation for the work that they do. So they go to their cohort hospitals on site, and they run simulations on various topics for increasing clinical staff competency and confidence. Two of the favorite topics tend to be sepsis, as well as neonatal emergencies. So this is a live, hands-on, experiential type of work. They do really good pre and post knowledge type tests, so we can see an increase in staff competence in those areas. And I believe Joyce Filnworth with our Indiana State Office of Rural Health is on the line. She might be able to speak better to how did we decide on this subcontractor, because she just came on earlier than I did in this process. But it's been received really, really, really well. And we're excited that it's now national accreditation.
Yeah, Angie, this is Joyce. And yes, I was getting ready to hit my unmute when Lori started speaking, but yes, I agree on the simulation. Actually, to step it back, go back a step further, because we contract with the hospital association, and in choosing them, we had worked on another project with them, on a coding project, and I believe it was even on another grant. And so from that partnership, then we chose them to continue to utilize them on our SHIP grant. And then from there, the hospital association, I believe, had worked on several projects with Rick, as it's called, on the simulation group, and had good experience. So then they were pulled into one of the projects that we would offer our SHIP hospitals to participate in. And again, we have a kind of a different format where we have 4 different projects that each of our participating hospitals participate in every grant cycle, in addition to our special innovation project.
So do you want to talk a little bit about your 4 projects that you do, and all the hospitals get to participate in those?
Sure. So the first project has to do with patient family experience. And that's really looking, mainly it starts with looking at their HCAHPS scores and figuring out where are the areas of improvement. Do they have a patient advisory council? How are they doing discharge planning? How are they doing their transition of shifting? All those things that obviously we're aware of that impact that score. And then the second one has to do with maximizing reimbursement in the outpatient setting. And so that will be, the project lead will go on and meet with the hospital that are participating in that, and really on a one-on-one determine what is their kind of gap analysis, and even perhaps do a gap analysis. Maybe they don't know what they could capture on. So she'll sit and look at their registration process, see if there's areas of improvement there. Are they getting a lot of claim denials because of that, because of errors made at that step? Is it their hospital-owned clinic that really doesn't have a wellness identifier or outreach program where they could capitalize on that? Are there opportunities to take some of their clinics and turn them into rural health clinics and capitalize on a higher reimbursement? And then the third would be the simulation that Lori shared with you. And then the fourth would be the mental health project with a focus on zero suicide. And then, yeah, and Lori actually leads that project. And then again, as I mentioned, we also have the Special Innovation Project, the SIP, where that project has a common denominator of health equity. Then with each of our currently 14 hospitals participating in that, they've kind of honed in on where they want to focus health equity. More than half have chosen to look at that from a behavioral health standpoint, mental health, substance use disorder. A couple have looked at nutrition. Some are looking at their diet, people who suffer from diabetes. But again, it's an overall from a health equity standpoint. And so each year they go through their hospital application, and we list for them the 4 projects, and then they rank by their interest which one they want to participate in that grant cycle. And then we do our best to honor that. With this year, obviously with COVID, offering them an opportunity to go back and redo the project maybe they chose last year, where they really didn't feel like they could commit to the level they wanted to, and really want to do more to fulfill that project.
Awesome. Now, when you were looking at subcontractors, to do these programs, how did you find them?
Okay, are you referring to the project leads?
Yes.
Okay, yes, so that was through the hospital associations, kind of our dual conversation. One of them actually also works on our Flex program, that organization. So we had a relationship with them. The second one has her own consulting firm. And again, we've worked with her. She used to work actually for us in my position at the State Office of Rural Health, and had branched out on her own. So she continues to work on several of our state contracts. So we knew that relationship and knew her expertise was in that maximizing reimbursement. And then again, with the simulation project, Hospital Association had that relationship with the RIC in Terre Haute, as Lori shared. The mental health has been one that Summit the Hospital Association has led. And as I mentioned, Lori's currently leading that. She is a licensed social worker from many years and has worked on several grants. So she brings great value to that project as well as our SIP project also is led by a hospital association who is kind of the guru, is my words, on health equity, has done several projects in the past on that. So she was chosen to lead that program. And many times we might bring in some additional partners that each of them are aware of. With the mental health one, we've worked with a couple different organizations that have extensive experience, especially in rural areas, that they've been able to add to that when we do those cohort webinars and so forth. Lori, I don't know if you have anything you want to add to that.
You covered it beautifully. Sometimes it's all who you know, and sometimes it's just experience that happens to walk through the door. So,
Yep.
Yeah, and I've asked Lori to join this. If people wonder why is she on the call, but I asked Lori to join this session because she took over this role a few months back, has worked kind of behind the scenes, but became our overall SHIP lead within the Hospital Association. So I thought it was really important that she kind of hear what I call from the HRSA horse's mouth directly about the work plans and kind of what we're looking for as far as outcomes go.
Yep. And great job. And this came loud and clear when we were having our one-on-one calls. I mean, and you can hear the energy in your voice when we were talking, just looking at, okay, what are you doing? And, it's just, these are the valuable moments that we don't always get to have as SHIP coordinators and writing our projects. And so it's very valuable. Anybody else on your subcontractors and a favorite project?
Hi, this is Kyle. I'm from the Wyoming Office of Rural Health. And so for us to do any kind of subcontracting, we usually have to put out a request for a proposal. And so that's something that I think we could use more information is what all do you put in? If you have to do a request for a proposal, if you have to put it out to the public, what do you put in that to identify what the deliverables are? And then because of that, I do work very strongly with the Wyoming Hospital Association. So the Wyoming Hospital Association is going to help with a board training. They're going to use iPro or iProtein for the board training, and the board training is going to focus around what HCAHPS are and why we're trying to improve them. But specifically for the SHIP program, one of the identified projects was cybersecurity. And internally for me to get an IT contract or grant agreement through like cybersecurity, it's almost impossible. And so I did some just brainstorming with other people on some ideas of how we could get cybersecurity training out there. And it ended up that we're going to be able to do it internally. Like that's who we're going to subcontract with is the Wyoming state government has its own cybersecurity team, and they are the ones who are actually going to put on the training for the hospital. So that was kind of an interesting way to work around and to find some collaboration right within our government institute. But really, when we subcontract, 100% of the time, I have to RFP it out. I can't, even though I've worked with people or I have a relationship, if it's a specific activity, then I have to RFP it out or request for proposal. Do other people have to do that? And if yes, what do you put in for your deliverables, or how do you figure that out?
Anybody else? And I see Sherry also asked a question too. How do you procure your vendors with a SHIP grant start date and then contract with your vendors? Does anybody want to talk about their RFP?
I can share with you, actually, we did not do an RFP. We have, and this was again before my time, so lack of better words, we have a mechanism where if we can demonstrate how the organization that we want to subcontract with is unique in its own right, so to speak, and there aren't other organizations that can really offer the level of expertise and basically be able to do what we want to have done, then we do not have to go through an RFP process.
Anybody else?
This isn't necessarily in regards to RFPs, but you said cybersecurity. And the first thing that came to my mind was, I wonder if any of your universities or colleges within the state have a cybersecurity type of education program, and whether there'd be expertise within that pool of people.
Right, that's where we went. We went internally to our state government that provides it for state government, and they've agreed to provide it for the hospitals. And then to address the thing about the RFP and that kind of the sole source, there's still a lot of discussion here around, like a monopoly. So even though we might be able to say this person provides this service and does a real good job with it, and we think they're unique in that, for me, the pushback is always, well, maybe they're unique, but we need to do this RFP to find out if they are.
This is Sherry. Kyle, I agree. In Texas, we have a stringent procurement process, which precludes me to do any type of real sole source, or so everything I have to do, I go out on bid and I have to write the specs, everything. And that's been one of the biggest drawbacks to doing anything in a huge collaborative or whatever, because we have to go out for bid. And it takes a long time in state government.
That was the next thing I was going to say. It takes a long time. And so to get that contract in place by the grant start date is really, really difficult.
Does anybody do their RFP for like a 3-year period, so you don't have to keep doing it over and over? Kyle's nodding yes.
Yeah, that's a good suggestion if everything aligns so that we can do that. So do we know we have funding for 3 years? Do we know that this is the activity we're going to do for 3 years?
We've done that in Colorado also, where we have a vendor or a consultant that we've worked with for, say, revenue cycle workshops, and then moving forward to the EMR workflow activities. That same vendor had the qualifications. So we did a smaller search for any other organizations. But another factor that we look at is this consultant firm is in Denver, it's in Colorado, They already have an established working relationship with the hospitals. So it really makes a lot more sense to work with this kind of a vendor. And so they did a 4-year proposal. My CEO said that our board won't let us sign a 4-year contract, but we took the 4-year proposal and then we just renew it each year.
Okay. Dawn, did you have a question?
Yes, my question wasn't about the RFPs. It was about the board training. Kyle, can you tell me a little bit more about that and what you're doing with that? And is it certified, or do you certify them afterwards?
Hi, Dawn. Right.
Hello.
So the way this happened was our Wyoming Hospital Association. I think this group, it's called iProtein, but now they're shortening to iPro. They offered all of our board members just this trial run of their virtual training for board members. And so then the response that we got back from the board members was it was a fantastic training, but it was limited to how many board members we could have. So we went back to them again, to iPro, and said, we heard back from everyone that this was really good. We want you to do this board, open it up to everyone, this board training, and that we want it specifically on HCAHPS. So we want the board training, but we want it to kind of center around what HCAHPS is so that the board members can be on board with that and understand where we're trying to go with that. So it's really something I worked with, I think his name is Jeffrey Adler with iPro, but I really worked with the Hospital Association to develop the contract and the deliverables. And it's supposed to start anytime now. Like, we're supposed to be able to open up the platform and begin the board training. What iPro did, though, is they're salespeople, right, Dawn? So they want to sell us something. So they tried to sell us on this much bigger, oh, we have all these other trainings out there and we can do all this other stuff. And then they quoted me a price and I was like, no, that's not going to happen. We need to stay focused on just the board training. Yes, they do get certification when they're done. I think there's either 6 or 8 modules that they can complete in their own timing. And yes, they do get certification when they're done. We're hoping that we'll have more of our hospital board members kind of on the same page as far as where we want to go with value-based purchasing and where we hope to take that activity. Did that help?
Totally. Thank you so much.
You are welcome.
Dawn, this is Sherry from Texas. So when you do the board training, one thing or lesson learned that we found, we did a board training and we're going to do it a second year this year. But so we did the board training. We had the Texas Hospital Foundation write the curriculum, and it was a full day, and all the board members of the rural hospitals attended because the urban hospitals have it didn't fit our rurals. So they created the curriculum. It was a full day curriculum, and it was through a webinar. But what we found out later is that our CEOs were really on board with all of this. But then after these board members took the class or took the training, they started micromanaging into the hospital. So one of the things you really want to make sure the curriculum covers is, it went through roles of board members, but you really want to make sure that they don't overstep and start micromanaging.
So kind of learning your role within the whole hospital or within
Right.
the whole healthcare.
And they had a whole section on they had like a 15-minute section in the curriculum about what is your role. Don't go into the hospital. You're not supposed to be just walking the halls. That's not your role. But a couple of my CEOs contacted me and said, it was a really good training. They did learn a lot, but, now they're kind of like, they use the word micromanaging. So kind of like getting into the business that they shouldn't be. So just be careful on that.
I think that's a really good point. That's an excellent point too. And I'm going to make sure of that too, that really for board training to understand what your role, what your function is, and to understand then what everybody else's role and function is within that. Thank you.
So really a summary of that would be help them understand what their role is not also, right?
Right. I mean, it was addressed quite well in the curriculum and in the webinar, but again, you have different personalities involved in a board membership. So, you know, I think I just wanted to bring it up as something, a lesson learned from us. So it may not even happen to you, but I think, you know, different personalities on a board can, you know, it just happened. And so I wanted to bring it up.
All right, let's go on to our next question. Anyone willing to share one of their favorite hospital projects? And here's where it's the outcome from the project and then how you shared that with others. And I don't see, is Rebecca on from Oregon? I didn't see her pop up, but I know she had a really good one.
She mentioned right before she had a conflict, unfortunately. She
Oh, darn.
tried to hop
Okay.
on, but yeah.
Okay. Anybody else have a really good hospital project? Anybody do any kind of an EMR workflow optimization? This is something that came up a couple times in my one-on-one calls.
I can talk about the one that we're doing in Colorado.
Okay.
We're doing not optimization, but we're doing EMR workflow analysis for data accuracy. And when we first initiated this project, it came from the EMR user groups we had several years ago, which was through another grant. And the biggest question that kept coming out of those user groups was my question to them: have you done any EMR workflow to map this out and, you know, figure out what's going on or how you can fix it? And so we're working with a consultant that we've worked with for multiple other projects, and we know their background is really good with HIT. So and with quality improvement techniques. So that is what we're doing. We set up a project charter to establish what was going to happen throughout the project. And we set up, as far as measures, we knew that every hospital was going to have a different topic or different focus. So it was hard to establish one specific measure. And so that's something, that's our challenge to be working on going forward. But with each project charter, the consultant helps the hospital identify what they're going to measure, how they're going to measure it. So by the time they get their project charter completed and their project completed, then they have identified what they were working on to improve and how they were going to measure that. So that's kind of a nutshell, kind of a overview.
And I love that, you know, and we talked about a lot of these things on session 2 of, you know, really looking at some of these outcomes. So when this is all said and done, how will you share so that, let's say we have a Epic user over here and an Epic user over here, and they both did different projects. How can you share some of that to help them not have to recreate the wheel?
What we'll be doing here, and I'm just starting with some coding stuff today, is we'll start peer learning groups. And so it'll be meetings like GoToMeetings or conference call where we'll all get together and talk about the projects we've done, because I still have all my records from my EMR user groups. So I know, and on my ship map of the state, I have a ship map of PPS hospitals and critical access hospitals. And then underneath their town name, I have what EMR they have. So I keep track of that on an ongoing basis so that I can help people network with each other that are on the same platform. And
Nice.
when I'm helping troubleshoot with some stuff, I offer that out that, you know, we can connect you up to somebody else that has the same platform, or I can connect you up with a HIM problem with somebody who is like 2 or 3 senior level people who don't have problems with this, and they can help you help yourself and things like that.
Great. Anybody else?
So I was wondering if Rebecca was mentioning in Nevada QAPI project. I'm not sure. Last time I'm sorry, I wasn't in the meeting because of the connectivity. And
So,
is that QAPI?
Kind of. It was the cultural competence, and she's presenting it at the reverse site visit, the Flex reverse site visit, as well regarding HCAHPS.
Okay. I'm not sure what she was talking, but I would just wanted to mention QAPI, that we have a subcontractor that goes to each hospital every year and kind of gives our office a report on where the biggest gaps, most of the hospitals, what are the biggest, most common gaps in the hospitals, and then we plan our activities and training and education on this report.
Oh, I love that.
And one thing is that we do right now rethinking on, you know, our measure was, I think it was very vague, just pretty much how many hospitals are assisted. But now we trying to, actually I met with Becky last week, and we're trying to figure out how we can pinpoint the measure so we can show that there was a difference. So we're working on this.
Awesome. Now, do you use a subcontractor, or who is your QAPI person that goes out and does the assessment?
It's a contractor, yeah.
Okay. And then for anybody, there was a couple of mentions on our last call of people that actually have a state website for project sharing. Does anybody want to talk about their resource site and its value, if you hear any feedback on that?
Our subcontractors, the Nevada Rural Hospital Partners, that's Becky with, but it's more on a flex grant that we have. Well, they built a really comprehensive website that you could see if you're a member and you sign in as a member. So each hospital has their sign in. You could share your data and compare one to another. Also on that website, there's all the information on all of the reporting that rural hospitals required, including MDQIP, and not just dates and requirements, but also why those reports are needed and required, and how to report, and also all the resources available to find more information. It's on. It would be, if you're interested, you just can go on the website. It's a Nevada Rural Hospital Partners, and you can just see how just how much information, how it's spent, and how easy to find everything on one website. And they continuously update if there's any updates. It's so just kind of advertising a good idea of the website and all of the resources.
Anybody else? And I think that's where, helping, some of our coordinators also look at how can we share, some of these best practices that we're learning from each of our hospitals moving forward in our resource kit. So thank you for sharing with that. Any other questions before we move on? All right, next one. Did I freeze up? There we go. All right, pre-assessment environmental scans. So this came loud and clear in both our calls and on sessions 1 and 2. Looking at how do we do those environmental scans to determine our needs if we want to, one, create RFPs, but also really looking at where can we find some of those ideas and, ask our hospitals to provide input on what is it that they need. I know a couple people do a pre-assessment or an environmental scan before the grant period and before they send out their potential consortium work, as well as just the applications, but just kind of curious if anybody else is doing anything. I have a few ideas on what to add to this. We do an assessment every year, and well, back when I was there anyways. And what it was we would actually talk to a lot of our speakers that we use throughout the year on what are the current trends, what are you seeing in this area, in this area, in this area. And we would start asking folks, what they're looking at, what they're needing, so we could create some of those potential consortium projects. And, like I mentioned earlier, the majority of the funds are going to individual hospitals versus consortium work. And we really want to enhance those consortium learning projects because so often they're too expensive for one hospital to do on their own, whereas we can look at it differently as a group, and hopefully get the price down. So just asking if anybody has any of their surveys, how they do this when they do their environmental scan. Nobody. And this was a tough one. This is, a little bit tougher for all of us and how we identify that. So, and like I said, at the end of all of this, you're going to get a little toolkit, and hopefully each one of these will have like a one-pager of ideas, of how to do this, how to do this, how to do this, and give you some resources moving forward as well. Anybody else have any ideas on how you, look at it at the end of the year when you're talking to your subcontractors or those you've used for speaking engagements?
Angie, this is Danette. In Colorado, we kind of do all of the above. We use little surveys, not a lot, because if it's more than 4 or 5 questions, people tend not to want to do it. So I will send out a survey, maybe on coding. Also, I listen to what our hospitals say. Back in 2016, one hospital came to me and said, where can I find training on injection and infusion? And I started asking around, and it turned out that a lot more hospitals wanted that kind of training. So we kind of took a vote, is this what you want to do for the next year? And we went ahead, and we've not only done that once, but a couple of years later, we did a workshop, regional locations around the state. And the vendor that we use they really put together a good training manual. So people have used those training manuals for years as their reference and resource. Other things, like you said, talking to speakers or trainers, various consultants that we work with to find out what's going on in the industry right now, what's happening with this, and making sure that we are covering the most recent, most urgent needs.
Awesome.
This is Lori with in Indiana. One other thought I had was we do have a SHIP advisory council made up of about 10 to 12 different hospitals who've identified a representative, and we get together quarterly. And I ask them what are topics and concerns that you all have, or what's your feedback on how the project went over the past year. So it's a small subset. It's not surveying all of the participants, but it does help get a wide variety, but in a more manageable group size.
That's an awesome idea.
That is an awesome idea. I really like that.
Mm-hmm.
That's a great one. And then do you rotate out your group?
So if you recall, as Joyce was explaining, every year that they can rank their project, there's also a question about whether you would like to add a member to the advisory council.
Awesome. I love that. Anybody else? All right. Next slide. There we go. All right, we're going to dig a little bit into the data and, start talking about the challenges everybody came through with and look at the resources and how we can really talk about this. And, I know data is hard. We talked a lot about the process versus outcome measures on our last session. And, those, I think we can easily rectify from the last session when you're writing your next grant. Just like some had said, we've already started talking about this, but now it's getting that data from the hospitals. So let's go to the next slide. All right, so these should look very familiar screens. The first one comes from when hospitals select. And it says, that they have to write in a little bit about their activity, which is like minimal. I'm using it to support press gaming. I'm using it for this, and then we have the activities progress, this is our, mid-year progress report of how are they doing? And this was the example provided in the template. So again, what the example is versus what we get from them tends to be a little bit different. And I think everybody kind of agrees with that, in that it's so hard to get them to submit something and look at it differently. So we'll go to the next slide. All right, so let's start with HCAHPS. In looking at our data, there's ability to trend data over time to demonstrate the value. As we know with our SHIP grant, we really want to show the value of what we've done. And we talked about this the last time. It's not necessarily just the number of people that we have trained or educated. It's did it make a difference? What impact did that training or education provide? If we're using it for our vendor fees, let's look at some of the data to identify some quality outcomes, kind of in a little bit backwards sense. So, we can have some baseline data and then to our present. And a lot of times what we found in Illinois was we had to really do this from a bigger picture. So we could look at data a year ago and then, 6 months and then to current. But we can also start looking at it in the respect of what else can they provide us without being burdensome. And even if we just start right now, just looking at everybody's work plans, and they were so varied in how we're measuring this data. If we start now, over the next 3 years, we will actually have some value-added proof of the value of the SHIP funding, to demonstrate what we're doing. So with that, we can look at our vendor. They're going to use it for their vendor. And so when we send back that signed agreement to our hospital, here's an idea, that we also include, how long have you been using this vendor? When does your contract expire? And then let's look at some current baseline scores. Now, some of this current baseline can come from MBQIP, but then, we don't want the most recent from MBQIP either. So, and I'll show you this again in a little bit. But what we really want to look at is, okay, in 2019, we were at this 85%, and now we want to move it to 90%. You know, how does that look? And we're going to get a little further into this. We're also going to ask them to provide the number of staff educated, trained, and then those resources and toolkits. And when I started talking with several folks on our one-on-ones, they were also like, ooh, I would love that idea of having some of those resources. You know, it's ideal. What we did with Indiana one year, we had 2 groups on 3 different topics that we kind of worked through. And here was one group of hospitals and here's another, and they both piloted different practice changes. Like Ask Me 3 on medication adherence and medication management, understanding their meds. And then the other one that practiced something else with a different vendor source, looking at, you know, how can we change this? And I can't remember our vendor now, but we started looking at some collaborative efforts. So we would have some resources and toolkits. So when hospitals decided, yes, this one, you know, is the one I want to go with, they had a selection to pick from. You know, just because we think about quality that they, you know, or HCAHPS that they purchase software, doesn't mean it was effective in changing the quality of care or the outcomes. So we want to, you know, challenge them a little bit on some of those measures. And again, we're going to go through this a little bit more here. So we'll go to the next slide.
Angie, this is Sherry.
Yeah.
And to me, what we're asking is what is the cost that they're for their HCAHPS vendors? Because like I told you during our one-on-one,
Yep.
It's ranging from $5,000 to $20,000 annually. And are they getting the benefit? You know, we're looking at it on a financial view of it also. So
exactly. And so, and here's the kicker, and I get so frustrated with HCAHPS. You guys, I'm very passionate about this one. You know, hospitals can report some of this themselves, especially if they have a marketing person or a staff member that can manage the mailings and the feedback and putting it into an Excel file so they can submit to QualityNet. You know, I was just recently in Texas in a very small hospital. They had one patient when I was there, and that patient got discharged and was not eligible for HCAHPS because they went to a nursing home. But, you know, they can do this themselves. And, you know, to pay $5,000 for a Press Ganey report that is nil because 1, you can't get star ratings, 2, you don't have enough volume to even get on Care Compare, or you get the little asterisks there. Your MB-QIP reports are very minimal to make a change or an effort change, that we have to find other ways to do this. And looking at those, you know, costs, you know, they could save a lot of money, you know, and how can we help them in looking at those efficiencies? You know, and finding, you know, somewhat ways to do that. You know, others, you know, if you have a lot of self-reporters, one hospital can report on behalf of several hospitals. There is a multi-hospital reporting mechanism, you know, that we can look at pooling, you know, and creating some avenues there. Again, you know, I don't want people to spend all this money just to say they have data for data's sake. You know, and have to be able to give us something that we can improve on. And Sherry, thank you for that, because I really do appreciate, you know, how we look at the costs of this moving forward, you know.
Well, and the other thing about CMS only does the self-administration for HCAHPS once a year in February. And so they're not helping the situation either for our hospitals who have such low volume. And Texas has such low volume.
No kidding. I was just there.
Right? I told you.
Yeah, mine was just an overnight, and it was, you know, unreal how limited, you know, that they have. So, you know, if we go to what was purchased, you know, and we start thinking about quality reporting, really get out there on the Rural Center's resource page on MB-QIP. There is a gal named Robin out there in the MB-QIP world, and I absolutely love her. Have her do a webinar for you on quality reporting of your data. She also does a deeper dive of, are you collecting the right data? I mean, she's just amazing. And I don't know if she's from Stratus Health or not, and Sally might be able to speak to that a little bit.
Yeah, it's Robin Carlson, and she's part of the Rural Quality Improvement Technical Assistances, or ARKITA team. And yep, she knows the ins and outs for the hospitals of actually reporting. I'll post her the contact info in the website. And
awesome.
she does
Thank
office hours. Ask Robin. Actually, there's one tomorrow. I'm just seeing on the website. Open office hours.
You know, and this is something I hear repeatedly from small rural hospitals is, where can we find resources? You know, who do we turn to? And, you know, if you go out there and, you know, just post them every now and then, send a blast email to your hospital peeps, you know, saying, hey, this is coming up just in case you're interested. You know, it really does help. And while it doesn't feel like we're doing a lot, it helps them overall. So, but when we look at the software, you know, they're using it to purchase something, but how long are they going to have it? Any prior baseline to start to measure its outcome and its value? We know year one of software implementation, you're not going to get hardly anything. You know, it's really going to be years 2 and 3 to really make it robust and do the work for us to figure out, does it meet our needs? And if it does, woohoo, okay, who else might want this? You know, what can we help to assist in that cost? And then, you know, keep that moving forward. When we look at quality improvement projects, how are they initiated and finalized? You know, and again, you know, what are the outcomes of these projects? When you talk to your hospitals and we look at those reports that they send back, and in the Torch conference 2 weeks ago, I was talking to one hospital and I was asking them about their SHIP project and what they were doing. And I said, so how do you write your report? Well, I just put a couple lines down because that seems to pacify. And, you know, I'm like, no, what else did you do? And then, you know, the CFO comes up behind and she's like, oh, no, we put this, this, and this in. And I'm like, okay. So, you know, what are the outcomes of these? And, you know, for her, the charge master review isn't realized until a year later, you know, but they were done, they were completed, and this is the outcome of what we had done with that. And then looking at, you know, if they're buying software, here's another question we can ask them, you know, to help them in the quality reporting, data collection, the anythings. You know, was there a prior deficiency? And we may see this on those MVQIP reports. One of the things that we have done, and I want to say maybe 4 years ago, 5 years ago, we started giving out some awards for MVQIP through Flex. Again, a little bit different, but we also started to recognize who wasn't reporting, and the Flex coordinators do get this information on who's not reporting on data, you know, so we can have a baseline of we were deficient in this, you know, we didn't have any population and sampling numbers in, and they can have that, and it tells them if they are eligible to report anymore, you know, so again, it helps them to identify that we're trying, we just have no data. You know, and that truly is a value add moving forward for our small and rural hospitals. And then looking at the number of staff trained and the number of education and resources and toolkits created. So, but anybody else doing anything different in capturing when they purchase software or doing that true quality reporting and data collection piece? You know, what else do they provide for you?
And this is a good question, Angie. I'm just looking at the last annual report to Congress. You know, there's over 400 hospitals out of the 1,500 that use the SHIP funds for quality reporting.
Yeah.
And then another 200 that were doing clinic quality measures. So if it was a provider-based RHC.
You know, and we think about the clinic quality measures, I know it talks about, and I don't know if I have that on a slide. Oh, I do on the next one. So we'll get to that one here in just a minute. But of our hospitals really looking at those quality improvement and data collection, what are they really doing? You know, what is it helping them in doing? Did they create a robust spreadsheet, a checklist, a something, you know, to collect this data through their system? Is it working with their, you know, EMR system to, you know, create those queries and those capabilities? And is it something others can learn from? And these are the things we'll start thinking about as we especially write next year's grant, and our applications moving forward. I'm anxious to see those next. Bye, Kyle. Thank you. All right. Provider-based clinic quality measures. This one I think is hard because when you look at it, it says, yeah, we're going to do this, but then let's pick a measure. It's not just the number of staff or providers trained. It's what did we do? And did we have a baseline? And now, granted, the majority of our hospitals, our provider-based clinics, are going to have a zero baseline unless we have some MIPS data that they're doing that we can use to move that bar a little bit. Now, this doesn't come on our MBQIP reports. This is something we're going to have to specifically ask. And then have them at least select one quality measure to report. And we have 200, that have selected this. So we know there's some changes happening and what kinds of change are possible, to share with others, when we start thinking about that. So when you guys look at your clinic quality, what do you ask of your hospitals when they select this as a measure? Nobody? Everybody's like, no, we need help. Give me something. And we'll pull a few things together for you to give you some ideas. And what I hope toolkit, yeah.
Oh, I was just gonna, I know there's only been a few states that are doing this, Angie. I think Michigan and South Carolina are a couple that have helped organize their provider-based RHCs for reporting.
So, and I know some do it through the QHI program out of Kansas.
Yes, I was trying to think of that.
Sorry, Mike seems to have decided she wants to be in my way. There's ways to look at blood pressure monitoring, immunizations, ways to capture some simple data just on improvement. And with QHI, you can do it on a national comparison as well. Right. The other is, I know Greg from Stroudwater has a really good pond program. And while it's not, totally provider-based clinic quality measures, it does give you some baseline, and you can select one or two from that as well. If you guys have not looked at that or looked into that, NOSOR has some really good information on that as well, to, kind of think about for even next year in looking at it. And I know it's very cost effective to do that as a state. So. All right, our next slide. Okay, this may take some work. Please bear with me as I go through this. And this is something, so we have Brian in Illinois, and he was our intern prior to getting hired on as our ship coordinator when the prior ship coordinator had left. And what we had started, and this is not his worksheet, I was trying to recreate it in my mind because I can't remember how he had done it. As an intern project, but we wanted to look at our hospitals and each measure they selected each year and start trending that. And what we found was, a lot of hospitals had consistently utilized CHIP funds for HCAHPS, but we weren't seeing any changes in their reporting, in their MBQIP reports that they had been having. So we started looking at other ways to help utilize their funds and what they were moving towards. And so one of the things that was we had the intern look at was how many started in shared savings, how many started in value-based purchasing programs. And you could look at it year over year, and it really gave us insight. It's like, wow, they really are doing something a little bit different, and each year they would split up funds or separate them out, or they would join a consortium work group on something. But again, when we start looking at data over time, this really helps gives us perspective of, okay, it's making a difference, and how did we do this? What can we do a little bit differently? And really start to, mesh some of this to show the growth and the sustainability of the projects that were, enhanced through the SHIP funding. Now much of the data, the ask, can come from our older data population. This is what we had in session 1 when we talked about, some of those campus and, prior reports that we have, our county health scores and some of those metrics that we have, as well as Care Compare, our MBQuip reports. And then there's a few financial reports we can glean as well in the cost reporting. So again, we can pull that for baseline, but then this helps us to really look at, hey, look at the difference this hospital is doing, and that they're not using the funds repeatedly for the same projects over and over and over and over again. Let's look at it as to what else can we do with this. And again, it's just an idea for discussion, when you guys are starting to write next year's grant, to look at where were our funds being utilized, and then it really helps to create that robust report at the end of the year and saying, look at what we've done, and engaged our hospitals. We've converted 3 or 4 hospitals into doing this with the dollars, to improve their quality of care scores, and looking at something a little bit different, or to improve their financial outcomes, in value-based purchasing activities, their efficiencies, their workflow, their dynamics, how they're doing things, their EMR, their charge master. Again, there's multiple projects we can go on that list with. So next slide. So I like this. I said, but Angie, hospitals are not reporting now. How can we ask for more? And isn't that the truth? And again, how to make reporting easier. That's the whole goal of what we're looking at in this learning collaborative. How can we make our information stronger? Okay, you guys just went blank on me. Are y'all still there?
Yes.
Okay. That was weird. Whew. So had a little panic moment. All right. So how do we make reporting easier? And when I talk to, all of you on our calls too, some had some really good ideas. But let's talk about, how the hospitals are reporting their data currently. We do have old data to provide that baseline and look back. But what are some methods that you guys currently do to keep it simple? And we'll look at some measures on the next slide. But when we go to that, let's talk about, how we really communicate with our hospitals, because you're probably thinking, well, I'm not going to do one-on-one calls with all of my hospitals. I have too many, and they don't want to spend time on the phone. So when we look at, our quality measures and get them to report, when we think about computerized provider order entry. Now, I know this one wasn't as often picked. There was a few that had this identified in their work plans, but not very many. But when we asked them, okay, did we institute this? And was it 100% successful? Did we capture every physician doing this by the end of the grant cycle? Or is it something that's going to extend beyond and go into the next grant cycle? What are things we can do differently? And then pharmacy services, looking at what did we institute for our pharmacy services? And then, we can go down that list. But just kind of curious, when you guys look at these and you talk to your hospitals, is there anybody that does anything very specific that you can capture data from them? And this is the hardest part, is getting that. ICD-10 software, that's easy. ICD-10 training, very easy. Cost report training, also very simple to look at and, to achieve those metrics. Telehealth, mobile health, I think those are a little bit more progressive in, the movement. We've used a lot of telehealth funding for the COVID era that we've been in. Community paramedicine, that was a big one. I think a couple of years ago, there was a lot of hot topics about that. I've not seen as much with that one lately, especially in the ACO world. It's been more in that care coordination, the CCM programs, PCM programs, and things like that. Anybody else have anything that they've been looking at in those investment activities?
Hey, Angie, it's Lori in Indiana. Under social
Yeah.
determinants of health screening, the
Yep.
hospital association is able to pull up the Z codes that each hospital has been using and what kind of prominence or frequency they're doing. And then doing a coding training for coders, and then being able to see after that training, is there any difference or shift in the capturing of Z coding?
What a great idea.
And telehealth, since that's likely to be, I think, more common, we'll see in this year since the pandemic. I know on the at F4HP with their network grants that they were, many of those use telehealth. They actually ask for the number of patient visits, and they look at, did access improve? You know, or number of patient visits.
Great.
Or maybe the type of, the other one would be maybe within the pandemic was the applications that you're using telehealth. It may have only been used in behavioral health, and now it's being used in primary care and patient monitoring as well for chronic diseases.
Angie, this is Joyce, and I would also say with our programs, probably the easiest one also is the outpatient reimbursement program we have, because if you identify a gap like in your wellness outreach or registration process, you can start to see that return of investment within a couple of months or so. So we can, that's an easy one to track.
Absolutely. I like that one. How soon do you recognize, success at that? I mean, is it usually within 6 months?
Yeah, it depends on the project. I mean, sometimes it can be even within a couple of months, and many times, like if they get accredited or something like that, we may not have those actual dollars in the grant cycle, but we definitely know what that projection will be.
Okay. Great. Anybody else have any? Anybody have anything under system performance training? This is one I didn't see marked on a lot. Anybody's done anything in workflow analysis and their system, lean implementation, looking at the efficiencies and building that into their system performance, or challenges you're having?
I think readmissions is often an area, especially for PPS hospitals, that we've seen either consortium projects or individual projects. And that's a measure that hospitals, even critical access hospitals, are tracking more and more, maybe for their Medicaid patients as well. And then the antibiotic stewardship.
Yeah. And I find a lot of people do more in the antibiotic stewardship in the Flex grant versus the SHIP funding, but this is a great way, and thank you for bringing that up, that we can plug that into the antibiotic stewardship. I did find out there were several hospitals that didn't even know that the survey was done and over, and it was a required NHSN survey, to really make sure that they are completing everything, to identify their gaps, in individual hospitals, and that these reports do come out on their MB-QIP reports, which takes us then to our next slide. which is quality. And this is something I've heard just about on every call is what quality improvement, really means. And I heard from 3, and somebody had came up with the Quality for Dummies guide, for our hospitals. How do you identify if I have a quality project? And I thought this was a really great idea. How do you help them do that? Identify, how do you drill down and look at, okay, do I have a problem or not? And in specific areas, especially if they're new, to really look at the funding to say, yeah, I want to do this. How do I know if I have a problem with this? And then help them identify that. And then the other piece was what is required versus voluntary reporting. And so when your hospitals ask you about quality reporting, what do you tell them? Because again, I heard this on multiple conversations on my calls, of, well, I don't even know what's required to help them identify where their weakest gap is. If all I'm seeing is MBQIP reports, that's not everything that they report on. Do you guys have a list of what's required versus not required? Yes, no?
We do. I couldn't tell you what it says, but I know we have a list.
Okay.
Yeah, and Colorado had a list go through the meaningful use timeline, where we had all the meaningful use requirements. We had anything that we could find that had a requirement for reporting. We had a big spreadsheet that listed everything, and then we did a crosswalk to see, what is reported in more than one place or more than one requirement. But that has not been maintained for a few years.
So in Texas, A&M, we the Flex program contracts with A&M University, and we have the MBQIP portal, and it has all the upcoming deadlines, HCAHPS, EDTC, OP2, all of those that are deadlines. And then they have one portal that they go into and then access and put the data in there.
And what about the rest of their required reportings, like through NHSN, any state requirements like their bed capacity?
Yeah, it has the Quality Net login, and then it has the NHS, the National Healthcare Safety Network, and then MBQIP database that they have login all in one spot. You can Google it. It's MBQIP portal. It's with A&M Archie, and that's through our Flex program.
Great. Anybody else? Someone had put out there about agile implementation. Has anybody used them to help your hospitals in QI projects, project discovery?
I have not. This is Lori. I put that text in there, but I've read the book and used it through kind of through a lean lens, but that's something I'm looking at creating more of next grant cycle, using this QI process a little bit more formally.
Nice. Which leads to that last bullet there too, a list of potential vendors. Anybody else have any other suggestions they've used for quality projects? And this is also where I was going to talk a little bit about Robin and the MBQIP group and their technical assistance. And then it sounds like Texas A&M has, their portal as well, which is great. I know Illinois has the mbquip.com resource page that has all of those very similar resources and EDTC reporting and things like that.
I put the reporting guide in there.
Yep.
I think in SHIP, I know it presents more challenge when maybe a third of your hospitals in SHIP are PPS, so they're not necessarily in the MBQIP reports you're getting. So then you have to go out to a hospital, compare. And then if you also include rural health clinics, and you have that third avenue. So just,
and it is hard when you have all of these sources that can provide data, but none of them speak to each other. And I know when I talk to, my hospitals, they're like, why can't we just report in one spot and be done? And I'm like, I get it. Unfortunately, we can't, so, I see all of the challenges, and we're one person, trying to pull it all together. And how can we do that? All right, we'll go to that next slide. Consortium, and this is our last discussion session. Woo! As far as slides, as we build our toolkit of resources and thoughts and ideas on how things have worked for all of us. So we talked about subcontractors. Now let's look at it in, some of these consortium work and the projects we've done. Have you seen any hospital projects that really could be moved over to some possible consortium work moving forward? And how do you identify those, to help us all kind of build that toolkit of resources in what we're looking at? Do you guys have any like quick tickler methods or anything like that that you utilize?
This is Sherry. So my biggest barrier to do consortium projects is the procurement.
Yeah. And this is a question because I knew we had talked about this as well. And this is more for going to be, I think, with Sally as well. When we have these, because of the procurement process, most of them being in the state offices, and having to go through that entire process, can hospitals say they want to participate in a consortium project, but they pay into being part of that? So that way it's not a true consortium as a procurement, but hey, we're doing this vendor, this subcontractor to do a lot of this work that you guys can pay for at a discounted rate or something like that.
Yeah, that certainly there can be existing rural hospital networks or consortiums. The funding would still have to flow, what was that word? To the state office, and then the state office, I guess could do one contract or one award to a hospital on behalf of the others, but they probably, would have to have the paperwork to indicate that all those hospitals are.
Oh, that's what we're trying to avoid.
Right.
Yes, giving
And
fiscal authority to one.
Yeah.
But I know like Minnesota, most of the awards are individual hospitals, but then there's a hospital network of about 42 and they get one award. Or some of you have systems, and maybe the system wants one payment on behalf of the 12 hospitals they have in SHIP in their system, and then they do the purchasing.
So Nevada has a consortium of all our 13 hospitals that exist in the state, and they participate in quarterly meetings for quality improvement and for infection control groups. Each group has a quarterly meetings, and that's where we work on MBQIP required measures together. All of the hospitals are really so far away from one another that they don't have any competition with one another. So they really share their measures openly, and we can talk during the meetings on how our data looking, how its measures looking, and what we should work as a group together. We pick the measure and work towards increasing quality or reducing the patient risk. So that's how we work as a group.
And I like that.
We also have, let's say, HCAHPS. We have 9 hospitals that use the same vendor, and this way we get better deal for the entire group. The better, it's a better monetary deal, yeah.
And you can access that, can't you, through that vendor? You can access their data too?
Yes, and that's the nice part, because we can access data pretty much as it goes on the true timeline. We don't have to wait for it's yes, I guess that's what it is. It's a true timeline. Whatever we have, then we can access. And also the vendors, if we request, they can, this particular vendor can provide the training on HCAHPS to the consortium group.
I don't know how this group feels about mixing small rural critical access hospitals with larger hospitals, but there are patient and safety regional coalitions across the state of Indiana. I believe there's 11 of them. And there has been activity of bringing back some of the participating hospitals and CHIP, bringing back to their patient and safety regional coalition some of the work they're doing. So then you get a little bit of a regional feel, but it's not a formalized SHIP activity at this point in time, but perhaps thinking about using patient and safety regional coalition type work could possibly be a way to create a consortium.
I like that. Does anybody participate with your state IHQ, your quality council? You know, everybody can go through CPHQ testing through the National Association of Rural Health, or with quality, but do you guys participate with your state quality organizations? I know in Illinois we have IHQ. I think it's the same for Iowa too, IHQ. But,
Angie, do you mean like in Indiana, is it the quality improvement organization, QIO, or?
Not the
Something
QIO. It's a little bit different. It's healthcare quality, Association for Healthcare Quality. And it's really bringing those quality professionals together.
So in Texas, we've partnered with the Texas, it's TMF, Texas Medical Foundation, and they have the quality contract with CMS. Is that what you're talking about?
No, it's a little bit different. It's just an association for healthcare quality. And I don't know if all states have them or just a handful of states. But I know there's some out there. And I think that would be also a really good resource for us to kind of tap into for the other quality pieces that are outside of MBQIP. And it kind of brings in for those PPS hospitals in looking at quality and what they can do as well. So I'll look at that and see if I can find some of that as well for our final resource. So,
you know, what we do with TMF is we've contracted with them, and we do the CPHQ training course, and so that they can get certified. But I don't know if that's what you're talking about.
Yep, they offer that as well. So that might be your Texas one.
Yeah,
I'm not sure. It's kind of like NOSOR has the national organization for each of the state offices, you know, and then you have your individual state offices. It's kind of the same thing. There's the National Association of Healthcare Quality, and then it breaks down from there.
Yeah,
into state organizations.
I think TMF is ours, and because they got the contract from CMS, and they're a quality go-to.
Okay. Oh, cool. And again, it's just knowing your resources to know where we can pull from. And when we're talking to small and rural, they always, you know, we used to always find they were like, you know, we're not going to do that because we don't want to be part of the CAHs. We want, something that's more specific to us, that's a little bit bigger than a CAH. And what can we do to assist them, and show value as well. Which then takes us to our literally last slide. Final thoughts. Love the hard questions. Again, what else would you like to see in that final wrap-up toolkit that I'm putting together now based on all the input from everybody? And a couple of you, I may be asking if I can use some of your stuff moving forward to put in our final little packet that'll go with all of our recordings. Back to Sally and Andrew. Anybody? I know Andrew has a couple of questions for you as well, some poll questions here at the end.
Yeah, thank you, Angie. I'll pull those up, and feel free to put your questions in the chat or unmute. But yeah, these are just some questions. You may recognize the first two from the first session, and then just some questions just kind of gauging how the learning collaborative was for you in your experience. I see Barbara put in the chat, I would love to know the process used by other states to develop a consortium.
Yep. We got to figure out ways to get around that whole procurement process with the consortium. And I know Sally's thinking, no, we can't, but we'll figure out some workarounds with that.
Well, as everyone's scrolling through the polling, and we really appreciate your feedback on this as we work towards deciding on a learning collaborative for next year, because we're actually working on our NCC, and Andy and Matt and I were just talking about that with Soleil and Janine. It seems we've been offering the learning collaboratives for 3 years now, and I've always been able to fill a cohort and then create a good set of resource materials. So we appreciate the feedback. And if other questions or ideas come to you as you're closing out the day, please send them to Andy, and we'll be working with Angie, as she said, to capture all these last resources and examples for everyone.
Any other questions, needs, ideas?
No, this is Sherry. I just want to thank you, Angie, and Sally and Andy. This was a really helpful learning collaborative.
And we're not done. We're going to get more stuff. And like I told everybody on the calls, I'm here. Call me, text me, email me. I will help you any way I can. And if I can't, I will reach out to my friend Sally and Andy. So
well, thank you all for your participation and sharing your best practices and resources. And thank you, Angie, so much for coming on as the leader and our subject matter expert for this LC.
Oh. All right. Well, thank you all. So you'll be seeing some emails coming from me as well, moving forward. By the way, one of the other questions that did come to me, and I'm working on it now, is, and this was also from Texas, from my hospital visit for my overnight down there. I had 2 CNOs, both brand spanking new. They've been in their roles very short time. They had no idea about state operations manual. They knew about swing bed portion, but not the rest of it. Quality reporting, looking at, am I doing the right thing? And I felt so bad because the chief nurse I was working with, I had her in tears, and I'm like, I didn't mean to make you cry. And she's like, no, these are happy tears to know I'm doing the right things. And so, it was good, but she's like, I have nobody to turn to and ask for help and guidance. And so one of the things I'm talking with Andy and Sally and my friends up there is how can we look at, or if we have any additional funds left over somewhere, you know, maybe building a CNO guide, you know, just a resource guide to help them get started, you know, of understanding. I mean, even the acronyms, the one nurse was from a trauma center, ER, the other was from home health. No CAH experience. You know, so we've got to find ways to help them be successful as well. And, you know, my goal is for you guys to all look successful and be your state resource. So we want to drive them to that, you know, and how we can help guide them moving forward. So I do hope that we'll be able to come up with some things for them. Oh. All right, I ran over. I'm sorry. I kind of thought I would run over more than this, but I did pretty good. So thank you all, and watch for more emails coming from me.
Thanks, Angie. Have a great day,
Thank you, Angie.
everyone.
Yeah.
Thanks.
Bye all.